Welcome. This is the Master Series number 2 presentation, All-Inclusive Image Processing Technique for Radiographers. Let's look at today's radiographer, the professional radiographer. Here we have 4 goals, and the first should be understanding how to acquire and process the images so that when they go to the radiologist, they are easy for interpretation. Number 2, have an in-depth knowledge of anatomy, physiology, pathology, and patient care. Number 3, knows what the physician needs to view to make a diagnosis and can provide diagnostic images that allow that diagnosis to be made. Number 4, is aware of both clinical and business aspects required to successfully provide imaging services. Because radiographers usually are the first and often the only medical professional to interact with patients who are scheduled for radiology exams, radiographers are charged with a great deal of responsibility even before the examination begins. How does a radiographer analyze the images that they have acquired before sending them to be interpreted? The technologist supervisor must accept responsibility for appropriate delivery of all images to the physician. Processes must be in place to verify that all exams performed and all images acquired reach their intended destinations. Processes must be in place to correct errors when detected. Let's discuss post-processing. Post-processing is an auxiliary purpose of image processing, and it is to improve the usability of the digital image. This includes imprinting demographic overlays, adding annotations, applying borders and shadow masks, flipping and rotating the image, increasing or decreasing magnification, and stitching or co-joining images for special examinations. This process may require a separate workstation. What is different and generally an advantage with digital radiography is the ability to adjust and optimize the contrast after the image has been recorded. To do this, we window and level both the contrast and brightness while the imaging is being viewed. Our goal is to optimize the image, not to correct mistakes when an image should be repeated. So misuse of image processing includes compensating for inappropriate radiographic technique or compensating for poor calibration of acquisition and display devices. The surreptitious deletion of non-diagnostic images. Get rid of those repeats, then let nobody know. Image processing to recover non-diagnostic images to prevent re-exposure should be a last resort and not a routine activity. Low-dose ionizing radiation poses no harm to the patient. A repeat examination poses no harm to the patient if we get the examination done correctly. A poor quality exam sent to be interpreted because we don't want to give the patient too much radiation can result in poor quality results for the patient and poor interpretations. Bad practice still translates into bad images. As a clinical director, many times when I was at the different hospitals in the medical imaging centers in Houston, what I found was as the students would interact with the experienced radiographers, the first thing they would say is, "That's what you learned in school. Let me teach you the tips and tricks, how we really do it." Well, tips and tricks don't get good quality images. Take a look at this swimmer's view that was actually done at a premier cancer hospital in Houston and actually went to the radiologist for interpretation. Do you see anything wrong with this image? Well, let's look a little closer. How about, has the exposure been altered so that you can see the cervical spine, but you've burned out a lot of the other tissues? And that is a direct result of, in this case, positioning. The area of interest is not over the automatic exposure control. Another practice we often see is somebody goes, oh, you know what? If you want to go upstairs and do a portable in the neonate unit, what I found is the best technique is just set it up on the anatomical programming for a finger. It works great. Well, yeah, that might work great for getting a capture of an image as far as you can see for the densities, but are the densities correct? And also, what is sent to the PACS, a finger or a portable chest x-ray? The impression that modalities using digital are all automatic or automated, and that you can adjust after exposures, each and every one of the exposures, to correct the images is not necessarily true. There are several factors affecting the quality of images, and radiographers or technologists are the key persons who are responsible in delivering good quality radiographs with reasonable radiation dose given to the patients. If you do it right the first time, you don't have to repeat it, or you don't have to fiddle with post-processing. Quality control of the technical parameters and radiographic positioning are therefore critical to a digital image. When we do projection radiography, CR and DR are not the same as film screen. And image density is no longer a reliable indicator of exposure factor control. We used to get a film and we would judge it and we would decide whether to increase, decrease the exposures, or how we would tweak the exposures for a repeat exam if necessary. Today, that no longer works. Today, you need to understand exposure indicator numbers, such as the chart shown here, and you'll notice that each and every vendor or manufacturer has a different methodology for creating feedback for the radiographer to judge the images. You must understand the feedback from your modality to post-process images correctly. So let's take a look at a portable exam that was done, and we decide we probably need to reject this one and create a better quality image. But the patient has left. So what can we do? Can we post-process the image and get a better quality image? Well, not really. The image you have is the best quality image that you're going to get in one sense. And post-processing, you may be able to optimize it, but you're not going to really change the image. So let's take a look at post-processing optimization. With digitals, we use a histogram, and we try to match that histogram for contrasts that we used to use in film screen. Therefore, we actually superimpose an H&D curve from film screen imaging over the top of a histogram and adjust the brightness and contrast, trying to optimize the image. Okay, let's see what we can do with this one. Notice here I have the screen coming up showing the image. I also have the H&D curve, which would be sitting over the histogram, and I can move that H&D curve through window and level of contrast and brightness. We can manipulate the digital data to improve visualization of the anatomy and pathology after the patient has been exposed, but we cannot improve the exposure. Here we see the same image. Let's start by increasing our contrast. It really was too flat, so here we're going to increase our contrast by about 40%. That flat image was just not bright enough, so we need to increase our brightness just a tad, about 10%. Although we have not corrected the exposure, we have optimized to the best of our ability the data we had to try to get the radiologists the information that they need for interpretation. So today we'll talk about image quality, what kind of changes you need to think about for technique factors, how post-processing works, quality control, and reprocessing for images that don't quite come out right, and what will impact all this has on the dose the patient has received. What makes for a quality image? Image quality is defined as imaging system's capability to record each point anatomically or physiologically in the object as a point on the image receptor or the pixel. Remember, a pixel can only be one color or one shade of gray, so it is the basis for everything. Our image quality would be influenced by contrast, spatial resolution or sharpness of the image, and noise or radiographic model. If we're underexposed, we kind of get a salt and pepper type look to the image because we don't have enough radiation. If we overexpose the patient gets a lot of radiation, but we do have the data there that we need to create a good image. The risk versus reward type thing is that we're going to overexpose the patient, and this is also often known as dose creep. An old saying in information technology or computer science is garbage in, garbage out. And this also is the same for image data. Poor quality image data in, poor quality image data out. Regardless of the acquisition technology, whether it's an X-ray room, CT room, ultrasound, etc., a good image can be produced only when fundamental requirements are met. If you take the image correctly to begin with, you do not need to change your techniques. And therefore, the patient gets the minimum dose with the best quality image, and you get the patient in and out of your room in the shortest amount of time. You must use appropriate radiographic technique, which means that you have to have the proper penetration, or KVP, for the tissue and the area of interest. You also need to have the primary beam, which is the radiation and how long we have the radiation set up for, or the mass, over the region of interest and collimated to the region of interest so that we only get the area we want to visualize. Our source to image distance, our SID, has a lot to do with the quality of detail. The longer the distance, the better the quality of detail, but the greater the radiation is needed because of the inverse square law. Collimation is one that drives me crazy because this is one people see masking as collimation. Masking on a digital system is not collimation. Collimation is when you take your original exposure, you want to set the collimator blades up so only within that area the detectors can be read. And to do so, you have to have your central ray, your patient, and your part all aligned correctly and positioning correctly. So in digital, positioning and technique are actually much more difficult than in film screen radiography. When we do our image review, we know that a quality image has to have sufficient density and brightness to display the anatomic structures that we are looking for. So we need an appropriate level of subject contrast to differentiate among the atomic structures. This means we need to have a good technique for the tissues and their attenuation. We also need to have good spatial resolution. We need to have as much detail as possible with a minimal amount of distortion. In addition, limiting the amount of quantum noise or model or the radiation to few X-rays is a concern because we get not enough data to work with the image. Many variables affect the acquisition, processing, and display of a good quality image, and the advent of digital imaging has created new challenges for the radiographers because to achieve good quality contrast, spatial resolution, etc., we need to understand the system or the modality that we're working with and how it acquires the image. The image receptor or detector is known as the IR. The image receptor intercepts the X-ray beam after it passes through the patient's body. In other words, it collects the remnant radiation that has passed through the body. The rest of the radiation has been absorbed in the body. By doing so, it produces an image in a digital form, and it is recorded on an active matrix of pixels and voxels, each one of which has a number that corresponds to the intensity of the signal for the area. The numerical value is married to a lookup table specific for the anatomy being displayed. There's really not a lot of difference in the attenuation in our anatomy. Remember, what are we mostly? Water? Okay, think about it. You want to get contrast, how are you going to do it? Well, we're going to have a very flat image, so we need to have a lookup table to change that image to reflect what we used to see in film screen imaging. The more and separate image detectors that you have on your active matrix, the more accurate the data collection is. If I only had 2 detectors on an image receptor, I could only record black and white. That's it. So for a given field of view, a larger matrix size includes a greater number of smaller pixels and therefore better resolution and more shades of gray can be displayed. The digital image is a correlation of the intensities collected on the image receptor, and they are married to a lookup table which gives a specific shade of gray for each pixel on the receptor. Remember, pixels can only have one color or one shade of gray. Now let's look at an unprocessed image or raw data. Notice how flat the picture is. We then take a look at the processed image and notice we have the same area of interest, but there is contrast and density that makes the image more visible. Well, how do we do that? Very simply, we again collect the intensities on a matrix. Those intensities are changed into a lookup table, and this would be where the processed image comes from. The process image is a reflection of changing the shades of gray so that we can visualize the density and brightness of each area. This is why we only do one image per exposure, and why we have to collimate specifically to the area of interest. Once you put in more data or your collimation isn't there, you confuse the computer and you can get poor quality images. Remember, computers are dumb. They're off and on. All they're looking for is a specific area to scan. They're going to scan that area and intensities on that area and say, this scan for this area is for a hand. And a hand is constructed with these different intensities. A digital image is not an exact snapshot of reality. It's only a discrete approximation at the time the image was acquired. The radiographer has control of both imaging parameters for technique and post-processing. The images sent to the PACS are the images that the radiologist must read. The radiologist does not have the original image that was acquired. They only have the images that the radiographer has chosen to send. The truth? Perceived image quality results from a cascade of effects and many, many factors, such as the sharpness, the system noise, the spot size, the pixel size, the subject's contrast, the bit depth. Bit stands for binary digit, and if I had 8-bit depth, it's 8 times 8, which would give me 64 shades of gray, whereas if I have 10, I have 10 by 10, which would give me 1024 shades of gray to choose from. Many of these factors are within the control of the radiographers and the designers of the equipment and media. You need to understand how your modality works and what each modality can do. It looks pretty easy, right? You just slap them up there and push a button and it's automatically controlled. Well, that's what people think, but it's actually much more complex, isn't it? The major factors that radiographers control are positioning and collimation, exposure techniques, and image processing and selection. Our concern is patient care and producing quality images, but we need to look at the big picture, the healthcare environment and what the healthcare environment impacts upon the patient and upon our ability to provide a good quality image. Remember, the global medical imaging market size was valued at $15.9 billion in 2020 and is expected to expand at a compound annual growth rate of about 5.2% from 2021 to 2028. DICOM, or Digital Imaging in Communications and Medicine, is one step lower or more basic than IHE, which is integrating the healthcare enterprise. DICOM actually gives us different definitions for the computer work that we're doing and what we're actually reflections of how the equipment was designed. You can see here with our DICOM header that we have a matrix that has 2,920 rows and 2,920 columns, which gives us a pixel spacing of 0.100 to 0.100, and the bit allocation, remember the number of shades of gray, is 16. Well, it can store 16 bits of data, but notice the highest bit, the most you could see, would be 15. It also gives you what is the largest value and the smallest value for the windows and levels of the lookup tables and what the window and level width should be. So this is the beginning of where we start in analyzing our images. How many people know how to pull up your DICOM header and take a look at it to know exactly what you're doing for that specific image? Imaging technology is evolving at a very rapid rate. And what's happening is that the vendors are all competing for the dollars and trying to make it more automated, less interface between operators and equipment. With doing this, they're kind of wasting their time if you don't know how to use the equipment, and the radiologist can't read the images that come off of the equipment. So education is a big limiting factor. And when you take a look at it, as each manufacturer has their own equipment, their own service, their own manuals for utilizing the equipment, and they have applications training, which unfortunately applications training is kind of like how to turn it off and how to turn it on. If you really need to understand your equipment, it's very simple. Get the manual and read it. The primary physical parameters that we're looking at when we're assessing an image are the image spatial resolution, contrast, and signal to noise ratio. In other words, do we have enough signal to get a good quality image? Okay, everything is going well. You've got a great patient. You've selected the correct anatomical program. Your exposure and patient position are right on. Your image is collimated and captured to the region of interest. Your patient has no prosthesis or body habitus out of the norm, and their pathology is not going to require you to adjust your position exposures. So you can go ahead and feel confident that if you have a great looking image and the exposure index factors are correct, that you have done the best and you can send that image on. Does each of your exams actually work that way? Are all your patients great patients? Does the body habitus make a difference? Does the patient interaction make a difference? Sure, so we're going to take a look at how we cope with all those. So when we take a look at our image, we're looking at the differences between what? Density and contrast of tissues. The real tissues that we're recording don't have a great deal of difference in their density. So when we take a look at muscle, we have an effective atomic number, say, of 7.4. Well, hey, that's the same as a lung. In fact, fat is only 8.3, and bone, well, we can't penetrate the bone hardly, but it's 13.8. So how do we get the contrast? How do we record the contrast and density to get the image quality that we need to make a diagnosis? To get the best quality image, we must understand how contrast is generated in the different tissues by the modality we're using and what parameters we set for that modality or the techniques. Because what we're looking at is we're looking at tissue, the density of tissue, and the combination of tissues to create images. When we're looking at our image, we need to understand that the raw data that we collect on the image receptor doesn't have a lot of contrast or density. We therefore take that raw data and use a lookup table to add the proper contrast and density for that tissue and that part in that position. Therefore, you cannot choose an abdomen for a chest exposure. Yes, you'll get a chest x-ray, but the chest x-ray will have the wrong scaling of density and contrast. It will have the scaling for an abdomen, and vice versa. Each body part and position has a standardized histogram that is used for reference. It would be nice if they were all the same, but they're not. Every single one is vendor specific for the modality you're using at that period of time. So you need to be able to look in your manual and find out how your equipment works and how to utilize either manual or automatic exposure control. Remember, the exposure is what we create. The image receptor traps the remnant radiation or the exposure, and that creates the raw data. We clean up the raw data of any anomalies or errors, and then we use values of interest, in other words, what contrast and density it should be, by using a lookup table to scale the raw data. So when we're selecting an exposure, we select the body part and the position, and it is automatically set up for the exposure and the body part that we're looking for that manufacturer. The problem is everything always correct? No, it's not. Do patients have different body habituses? Yes, they do. So if you look at collecting the data, the raw data, you need to understand how to create proper exposures for your patient that you're working on at that time with that equipment. Once you've made those exposures, you can see over here to the right, we actually have our histogram, and they're taking the raw data and changing it into the expected image or the expected data through the lookup table. We can only take quality data within a certain range and create a proper image. The image may look proper, but if the exposure indicators indicate that it is not, guaranteed you're going to miss some pathology. Let's start by looking at the upper left image, which is the patient interaction of tissue with ionizing radiation. We can see that the patient is receiving ionizing radiation. That radiation will either go completely through the body without interacting at all, or it will be totally or partially absorbed with the photoelectric and Bremsstrahlung effect. Or the radiation may be scattered. In other words, the excited photon comes in and kind of bounces off the area and shoots off to another area. Well, is scatter radiation scatter radiation makes up the majority of what we find in the remnant radiation that we've recorded on the image receptor. And we can control the amount of scatter radiation, etc., by setting up the correct technical parameters. We're talking about the right density and the right contrast. What is the exposure factor used? Now, we see a step wedge, and the step wedge is used to measure contrast and density on an H&D curve like we used to use with film screen. Remember the toe, the straight portion, and the shoulder? Back in old X-ray school again, huh? Well, we're not going to have to go through all that. But the point being is that we're going to get an exposure, but in that exposure, we need to take a look at the data that was collected. Is all the data collected going to be useful? Obviously, the answer is no. And that's why we have the lookup tables and the histograms, because we only want to collect the densities for that part at that time on that patient. So we end up with a range of densities that are useful, and these intensities can be changed into shades of gray to create an image. So let's begin by saying scatter radiation adds absolutely no information but can detract from the information that you're trying to collect. We begin looking at our exposure, and that is the correct area of interest. We collimate to that area of interest, and we use an exposure for that particular area of interest. Positioning and exposure techniques are critical. Poor quality positioning, collimation, and poor exposure factors will be reflected in your exposure index number. You need to understand for your vendor how to interpret the exposure indexes when you're analyzing your image. For a digital image, what do you look at? Well, you look at a monitor. The monitor displays your image. Is there a difference in the quality of monitors that are used in medical imaging? Yes, there is. We have the diagnostic monitor, which is used by the interpreting physician or the radiologist to get a diagnosis. We have the QC monitor, which is the monitor that the radiographer or technologist takes a look at when they acquire the image to make sure it is within the correct parameters. And we have a referential monitor, which is the monitors that the referring physicians, nurses, doctors, people on the floor take a look at. Now, does a referential monitor, something that somebody's on the floor taking a look at, need to be the same quality as a diagnostic monitor? Nope. In fact, the biggest thing is what? Cost. Cost impacts upon quality. The American College of Radiology has a standard for the quality of monitor that the radiologist should have. But again, that is a standard. Does that mean they have to have that monitor? No, they don't. The ACR recommends a 3 megapixel or greater monitor for viewing images. Now, does the QC monitor have the same resolution, contrast, and density as the radiologist monitor? Sure wish it did, but they don't. And does the referential monitor have the same contrast and density and resolution as a QC monitor? Probably not. Close, but probably not. So do you see a problem here? Well, the problem could be you could make a great exposure, and as you're looking at your monitor for QC, there's pathology that you can't visualize because your monitor does not have enough resolution, contrast, and brightness to show the data that you've captured correctly. Meanwhile, that same data, when seen by the radiologist on the diagnostic monitor, shows the pathology very, very well. So what we look at is, wouldn't you like to have the same monitor the radiologist has, because the image you send to him is the image he's going to interpret, or she. If the DICOM calibration of the display monitor you're using to develop your post-processing techniques does not match the display from which your radiologist is reading, much of your work will be done in vain. You'll be looking at different things. Well, this is an interesting image. Do you take a look at the left upper lung there and do you see the lesion? This type of image was used in calculating or creating the calibration quality assurance tool by the AAPM, the American Association of Physicists in Medicine, Task Group 18. And what they were looking at is how much density and contrast difference would it take to miss a lesion like this. And they came up with 2 pixel shifts in contrast density can mean missed pathology. And this is how they designed their calibrating tool for the monitors. Here we see the monitor calibration tool designed by the Task Group 18. And what we're looking at here is we know that raw data doesn't have a lot of density and contrast differences. We know that that raw data has to be changed into contrast and density that can be viewed well on a monitor through lookup tables. But we also know that the monitors need to be calibrated, because every human being has a different visual dexterity or visual perception. No two people see things exactly the same, but we want to get everything mathematically set up so that we can get the monitors that we need to analyze the data and the images that we produce. When we create a digital image, we must also consider display and the display environment. Visual perception is sensitive to luminous and contrast rather than absolute luminous values themselves. So in the reading room, we needed to set up a type of calibration for monitors that would actually reflect the human vision. Humans are able to discriminate between 700 and 900 shades of gray for the available luminance range of medical displays in optimal conditions. Well, what does all that mean? Well, I could see all these shades of gray, right? Well, you can kind of go like, well, you don't need more than 10 bits of gray because you can't see more than 10 bits, but hey, I know we're collecting more than 10 bits when we do mammo because we're trying to get the relative data. So how do we figure out this contrast thing for the monitors? Well, it's not like the monitor you would buy. Yes, I can go to Best Buy and buy a 3 megapixel monitor or a 5 megapixel monitor, which would be very cheap compared to a medical monitor. Medical monitors are designed and calibrated totally different than commercial monitors that are used just for TV or computers. In the context of medical displays, they're calibrated on what are called JNDs. JND means just noticeable difference. What they did is they took a group of people and they showed them different luminances and shades of gray, and they were asked to say, when can I see the difference, at what point? So they went through a whole range of these, but the point being that on the average for these people, this is specific to the human eye, and we're going to calibrate our density and contrast to the human eye and not a mathematical system set up like on your computer. So for diagnostic images and diagnostic monitors, we're using monitors that A, are of a much higher quality, and B, are more precise. But again, they are not graduated or calibrated on straight mathematics. They're calibrated on the human eye. So I remember one time that, one of the hospitals in the medical center, the equipment people decided they'd switch out the monitors, and we'll go buy a 5 megapixel monitor or a 3 megapixel, whatever, and they swapped them out in the surgery suites. Well, the problem was they didn't get medical imaging monitors, they got computer monitors. And let me tell you, did it hit the fan. Anyway, that's kind of what we're talking about here. You have to understand how things are actually done in the real world and what image contrast we're looking for and what kind of display we're looking at. So when we take a look at our monitors, remember we talked about cost and a diagnostic monitor, a QC monitor, and a referential monitor. Can you see how the cost factor applies in acquiring the different monitors because of the quality of the monitors that are required to image? I can use a regular computer monitor for a referential. I mean, you know, physicians don't even look at the report hardly. I mean, they look at the final interpretation. This is what it is. They don't read the entire report. So anyway, just an idea there. Now, let's get back to what we're looking at here. When we're communicating images to the PACS, it can be beneficial to send the values of interest and lookup table sequence for application at the display. What are we sending to be displayed? Well, we can see here that we have the exposure data that we've collected, and there's some data that is unused in one portion of the range. To the left would be the underexposed, the white, and to the right would be the black or overexposed. And in those, what we're looking for is a range or a value of interest for the exposure data recognized. We can then take that value of interest and utilize an H&D curve afterwards to post-process for our brightness and contrast using window and leveling. Well, we've seen how the raw data is transformed into the data that we visualize on our display, which is called presentation values. And we know that the raw data was corrected to begin with. They take like a positive and negative of the data, add it together and average it, and that gets rid of some bad pixels and dark noise and gain and stuff like that. It gives us a good starting point. Then we utilize that data with our lookup tables, and they are calibrated to what are called presentation values. In other words, these are calibrated to the values that were done on the JNDs of the human eye. And to know that we have the correct data in there, we look at our exposure index calculation. The EI, exposure index, or EI number, is a manufacturer-based number because remember they have proprietary fields that tells you that the range that your numbers that you acquired is in the good range or out of the good range. And we'll take a look at some of these exposure indicator calculations to give you an idea if you need to repeat an exam or not repeat an exam. Remember, digital images are not film screen images. With a digital image, we have a total loss of visual cues. That's why we use the exposure index number. We also have a very wide dynamic range. In other words, we can see more on a digital image than we ever could on a film screen image. Our digital images have automatic rescaling and image processing. And there is a relationship between the radiographic factors and appearance that has been decoupled on the digital image Remember in the old days when you had film screen? Some of you are probably too young to remember that, but unfortunately I'm not. We used to say, well, if it's too dark, you cut it in half, the mass, and if it's too light, you double it. Or you could use the 50-15 rule and adjust the KVP instead of the mass and go up either 15% or down 15% in KVP to either double or cut it in half as far as density goes. That doesn't work with digital. Mass, density, brightness controls and KVP contrast have nothing to do with our image. What we're looking at is our KVP, and our mass has to do with our exposure and the interaction with tissue, not the final image, although it does create the final image. Therefore, the physics of digital imaging are more critical than the physics that we used when we were doing film screen. Let's break the imaging process down. The first and major portion is accomplished by the radiographer or technologist, and this is the acquisition. This is the interaction with the patient. This is the ability to understand how to set the modality up correctly to get the data that they need for that particular examination. And then, after setting the techniques, acquiring the data. After the data has been acquired, we need to do pre-processing. This is where we get rid of all the extraneous data that we don't need, clean up the bad pixels or dead pixels and other defects, and use our histogram to get the contrast and density off of the data for creating the image that we would like to display. After the image has been displayed, we can enhance that image either by using equalization, different filters, contrast and detail, noise reduction, or advanced visualization techniques like annotating the demographics on the image, etc. We've captured the data, but we notice there's some problems with it, some minor problems, and the image needs to be optimized or tweaked. Can we do that at the QC station prior to sending it to the radiologist for interpretation? Yes, we can. Let's look at some of the things that we can possibly cure or fix or tweak prior to sending the image off for interpretation. Here are some potential errors. Now, is it possible to fix those errors at the QC station? You bet. You can correct a lot of these errors without having to repeat the exam, but it's also a judgment call. What we're looking at here is the fact that if your exposure index number indicates that your data is incorrect, you really need to repeat the examination. If the manner in which you collected the image or got the correct data for the exposure index needs to be tweaked, then yes, we can do that at the QC station. We can correct for exposure field recognition, histogram rescaling, grayscale, edge restoration, and one of the things that we do not have the ability to correct for is to add data to the image. But we can take a look, and if we are underexposed, yet within the range we're supposed to be, we'll have a noisy image, and we can try to reduce the noise somewhat. Also, if we would have set the image up correctly to begin with, we wouldn't have to reorient it. But sometimes you capture an image and left is right and right is left and up is down and down is around. But you can reorient the image. So yeah, there's a lot of tweaking we can do. And this is very dependent on your knowledge of what is being looked at, why it's being looked at, and what is the quality of the image that you've produced. The exposure data recognized is the data that we are going to use to connect to the lookup table so that we have the proper contrast and density for the image. A histogram is a two-dimensional graph of the intensities that we've collected. When we take a look at our histogram, we can see that there's a portion that would be unused in the dynamic range, either underexposed or overexposed. We also need to be able to make sure that the data that we have collected is in the correct range for the VOI, or values of interest. We can use this data and post-process at the console by taking an H&D curve over the histogram and moving it to try to do some of the tweaks we discussed earlier. Image post-processing is not a panacea. Frequent post-processing by technologists is going to result in inconsistent image quality at the radiologist viewing console. We need to have quality images as much as possible, and the images should be standardized. If you have routine reprocessing, it can indicate a problem with the automatic imaging processing or with the technical practice of the operator. To correct the modality, you need to have the ability to go into the software and modify the software for what the output of the modality is. Remember, as equipment ages, the output changes. So by having the ability to go into the software, we can modify the software or optimize the software for our facility. We use the term dynamic range a lot, and I'm going to show you pretty soon, in fact, the next slide, as what dynamic range really means. From a technical aspect, it is the optical density on the H&D curve above base fog. It is the number of shades of gray that an imaging system can produce. Interestingly enough, we talk about 700, 900, 50 shades of gray, forget it. Realistically, scientists say that a human being can actually only see 30 shades of gray. That's to see 30 shades. But the idea is that we can collect more than 30 shades to be able to view the image as a whole. The dynamic range of digitally acquired images is far superior to images acquired using a film screen system. So we have many shades of gray to choose from, lots of data to choose from. And if we take a look at this lateral skull that's showing the sinuses here, what we're going to see is that we have a range of exposures from 0.5 mass up to 83 mass. The area that we would be using are our exposure index, indicating what we should be using typically would be 1 to 4 mass. If you look lower at 0.5 mass, you'll see that the image is somewhat speckled or grainy. If you look above 4 mass, the image has a lot better quality in a sense, but it also takes more radiation. In fact, all of these exposures are over ALARA, as low as reasonably achievable for the dose. Remember, if 2 mass would be the correct dose for an interpretation, ALA allows you to either go up to 4 mass or down to 1 mass as the dynamic range that is suitable for the image. Let's take another look at the dynamic range here, and let's take a difference between the 0.5 mass on the far left and the 63 or 83 mass. My bifocals aren't working really good right now, but the whole point is it's 83 on the right. Well, what that represents is the amount of data that we had to work with. So if we're down at 0.5 mass, notice we have some speckling. We have noise in the image. Now, as we go over exposure, what we find at the far extreme on the 83 mass is we're losing our contrast. Notice the more exposure we get, the less contrast we have. Again, in film screen, we didn't have as good a dynamic range as we have in digital. In digital, we have a good dynamic range to choose from, and if we understand how we can come up with these images to set our techniques appropriately to get the best quality image for the exam that we're doing. So the term noise has to do with your signal. Do you have enough signal or enough radiation to get the data you need to create an image? And to the right here, we can see if we have poor signal, we get a noisy image. But if we have a lot of signal, we get a strong signal and we get a lot of data to choose from. The differences here are very simple in that if we overexpose, we're losing contrast, as you can see on the far right. If we underexpose, we're losing data, so we can't put any data in there if we don't have it. So the idea here is very simply, your exposure index number should allow you to see where you are in the dynamic range and what your exposure should be. Digital exposure is linear, and the exposures emulate traditional analog images. Imaging quality, however, is in the eye of the beholder. It's subjective. Whatever the person's looking at would be the image quality. So image quality is designed by the observer's ability to achieve an acceptable level of performance for a specific task. Does this mean that we should be able to choose the amount of data that is required for the image? You may have heard the term filtering. When you're creating a digital image, you can filter the data or add and subtract from the data to either smooth or sharpen the image. So you can actually select the amount of analog signals that are being sampled to create the digital signal. We'll show you the difference in the amount of data in the next couple slides. This one shows that we are sampling every 5 pixels. On the previous slide, we were sampling every 5 pixels. On this slide, we're sampling every 10 pixels. Are we sampling more or less information? Well, obviously, we are getting less information because we're only sampling every 10 pixels. And here we see a complete data set where we're sampling every pixel. So you'll notice the amount of information is much denser here, or greater. By choosing our sampling, we can actually filter the data to create different types of images. When we talk about image selection by anatomy, what we're talking about is we're selecting the exposure factors based upon the anatomy that we are imaging. And we have some modifications to that, such as small, medium, and large. These are anatomically specific algorithms. It is a PA chest, lateral chest, oblique chest. Each one has a different lookup table to get the contrast and densities that we're looking for. In digital imaging, positioning is critical. What we need to do is to be able to position the patient so that the area that we are exposing matches the anatomy of the lookup table that we have chosen. Anatomy must be placed directly over the correct detector. Certain anatomies that works real well, like if you've got an abdomen, but sometimes it's really hard, like when you get a sunrise view or you're looking at a cross-table lateral hip, or you're looking at an axillary view for the shoulder. That often makes it very difficult for positioning, and you need to be aware of that, and it may affect your end product. Because certain anatomy does not position as easily. Not only certain anatomy, how about certain people? How about children, or possibly a trauma patient, or an infirm patient? So why AEC might work well on everybody, will it work well on children? No, because they're moving around. How about the trauma patient? No, because we're looking at trauma. We're being two-part film alignment exposure. Two-part film alignment exposure. So when we use AEC and when we use manual technique, makes a difference, and positioning is critical in digital imaging. Here's a real simple one. Without the proper positioning in collimation, will you get the data you need to create an image? Image processing will eventually fail to process any image when the input information is totally different from what it expected. Okay, let's put it all together. Let's take a look at the histogram on the right. And superimposed on that histogram is an H&D curve. So we're looking at the H&D curve along the linear portion of the H&D curve. The slope is where we want to be able to have the majority of our information. Here on the left, we see that we're doing a lateral knee. The histogram correlates to the lateral knee, and the histogram is going to be read by a lookup table. Well, let's take a look at the A, B, C, and D on the histogram, and let's take a look at the A, B, C, and D on the image of the lateral knee. Notice that the knee is collimated, and so on the outside in D, we have scatter secondary radiation, but it's underexposed because of the collimation. By using the collimation, that is the area that the computer will read to create the image. Now, we talked about it earlier. There'll be no absorption going on, so the photon goes straight through the patient, this would be A. Nothing has been absorbed. B would be a partial absorption, and C would be more absorption associated with the tissue. So bone and muscle and fat tissues have different attenuations. And again, D shows us our scatter radiation. And remember, scattered gives us absolutely no information for our image. Now let's see what happens when we move the H and D curve to the left and the contrast and density that appears in our radiograph. It's the same as radiograph, we've just chosen a different portion for our samples. This is how we tweak images once we receive the acquired image to get the best quality image to send to the radiologist for interpretation. So how does the modality read the image receptor? Basically, it starts in the middle and works its way out to the collimated edges. All the information that is inside the collimator is scanned for data to create the image. Everything outside the collimator is left. As you might have guessed, here is my pet peeve. Masking and collimation are not the same. I am collimating to create an area for the modality to get the data it needs to create the image. If I'm masking, all I'm doing is covering up an area that has no data on it. Well, let's think about this. If I collimated down to a small area and we brought up the entire image on the screen, would there be an area on the screen that didn't show any type of data? Yeah, that is the area that we mask off. We bring the masks in so that we have a homogeneous area for the radiologist to look at and to read. We don't use the masks as a substitute for collimation. One thing, obviously, at this point in time you recognize is that you have to collimate down to the area of interest to get good diagnostic quality information. If you do not collimate at all, you get a lot of saturation in the area that you're trying to calculate. Without collimation, we get oversaturation. In fact, we lose the image. The image to the left was collimated to, and then the masks were brought over to cover the area that the light was coming through on the monitor. That is the correct way to do it. If you try to have the monitor completely filled so that the radiologist does not have any white light coming at him, and you keep the collimation wide open, you're not getting the exposure that you need to get a quality image. There is a difference between collimation and masking. And here's why we collimate. We collimate so that we can get an area to read, because as you can see here on this knee, the image is very flat, especially with the prosthesis in the knee. So we need to collimate down to an area that we need to see. If we open this up even wider, it would end up being even flatter. This is called image segmentation. The computer must establish the location of the collimated border of the image. The computer then defines the anatomic regions within that area so that it can look up on the values of interest on the lookup table. By using the lookup table, and the histogram, we're able to change the data to make an image for interpretation. Take a look at this image where we look at the densities that we have between air, fat, lung, liver, blood, muscle, bone, and metal. Notice the absorption or the transmission of data through those areas changes based upon the atomic number and the thickness. So we have basically 5 things that we look at on a radiograph. They're metal, bone, soft tissue, air, and fat. And we're looking for the combinations of all of those. Those combinations are what is recorded in the histogram. So we want to collimate to the area. We want to record the data that we need. And then once we have that data we need, we can use a lookup table to get us our values of interest that creates an image for the radiologist to interpret. Remember, a histogram is just a two-dimensional graph of the intensities that have been recorded. There are basically 3 types of histograms we use in imaging. But for now, we'll just say that a histogram is a graph that shows how much of the image is exposed at various levels. A histogram represents how many pixels each intensity level has. Here we see a nice depiction showing a histogram and the histogram on a control panel or a QC panel on the imaging modality. And it would be great if everything looked exactly like this. But again, each manufacturer does their own thing. So you have to find out where the histogram is and how to use it. You have to look up all the tools that are available for you to optimize your image. But here we can see very clearly the histogram with the H&D curve over it. We also can see the little levers or buttons we can push to change the brightness and the contrast. When we change brightness or contrast on the histogram, you'll see the H&D curve move over the histogram to reflect our choice. Remember, we had different kinds of histograms we use in medical imaging. Well, one would be for tone scaling, which we see, and the other would be the lookup table. The lookup table is a reference histogram. The lookup table is used as a cross-reference to transform the raw information. The lookup table is used to correct values. The lookup table also maps those values to a specific area. All pixels are changed to a new gray value that reflects the intensity of the exposure at that point in time and at that particular coordinate. The image, by having a lookup table as a cross-reference, will have the appropriate appearance in brightness and contrast as compared to a film screen type of image we used to use in the past. There is a lookup table provided for every anatomic part and every position. And we can go into the software and modify those tables to get them more precise or to optimize them. The histogram is basically, remember when you were a kid, you did paint by numbers? That's kind of really it. You're going in, you've got the number, you put the density and brightness there that is in that position. That's all it really is. Paint by numbers. We can generate a histogram by taking the scan area and assigning it an intensity and a pixel. You can calculate for specific anatomy and procedures. Chest, PA, chest lateral, chest oblique. Each has its own histogram. You can determine the data and the frequency to analyze. You can also change the data to either smooth or enhance the images by adding or subtracting out information. Remember we said histograms are like paint by number, so they have to be shape specific, and you have to be able to see the different coordinates on those shapes to assign the intensities. So if we take a look to the right, we can see black and white. That would be the histogram for both images, but since we need a lookup table for the values of interest, we have to go in and assign a lookup table, and now we can assign the black and white to specific areas. Very different scenes may give a strikingly similar histogram. They're applied globally to the entire image, and this can be a drawback in very complex scenes. In other words, where I've got a lot of different tissues and anatomies. Spatial information about intensities values is thrown away. We're just simply mapping the intensity values. The lookup table allows a display system to map pixel values or grayscale values with a range of brightness and contrast to a specific area. As we discussed earlier, we can change the brightness and contrast and add and subtract data to tweak the image. Let's take a look at some images and how they're reflected with the H&D curve versus the histogram shape. Here we can see that the peak of the histogram, the only thing that is recorded along the shoulder of the H&D curve is the black, the dark at the top. So therefore we are overexposed. But that is how you take a look at it. The H&D curve has moved to the left so that right here at the peak of the intensities on the shoulder, it is black, overexposed. Remember, in looking at an H&D curve, what we're looking for is the slope of the curve. The slope is the area that's going to be mapped. Notice here, we've moved the H&D curve over, so the slope is not hardly on any information at all. So now we have a underexposed image. As you can see, the histogram does not move. By using brightness and contrast, we can move the H&D curve over the histogram to select the data we need to create or tweak the image to its best optimum to send to the radiologist. All digital systems have extremely wide latitude, which means that connected to a display system with relatively narrow dynamic range, we have a lot to choose from. Digital images have extremely low contrast. The primary purpose of image processing is to maximize the contrast of the part of the image that contains the relevant clinical information. So we have all of the information on this image. We just need to tweak it to show the relevant clinical information or optimize the relevant clinical information. So here we see an image that we need to tweak to get the best quality image. We see the data in the histogram. So we can move our H&D curve over the area of interest and optimize the image. Remember, we're just using window level and contrast. X-ray images are binned into a histogram whose general shape is anatomically specific. The overall location and magnitude of the histogram peaks are used to segment the image and supply or apply the values of interest from a lookup table. Here we see a typical chest X-ray histogram with the pixel values that are ready for processing. The histogram x-axis represents the exposure amount, and the y-axis displays a number of pixels for each exposure. Now, if we take a look to the right, we can see that the values differ based upon where the information lies. So we can see to the left here, we have white values, to the right, black values. So if we have a wide histogram, that would indicate we have low KVP. In other words, a lot of contrast. If we have a very narrow histogram, that would indicate high KVP, which means that we have lots of penetration. An underexposed histogram would obviously be skewed off to the left because there is no exposure there. For an image to be a normal one, which is not too bright or too dark, the histogram must have an almost equal number of pixels at all intensities. When the pixels are distributed over the intensity values, there will be a very good contrast in the image. Well, to summarize this, we might say we're doing a paint by number with light and intensity. So really what we're looking at here is different image densities. And we have bone or calcium, soft tissue, air, and it is a combination of the atomic number and the thickness of the tissue that creates the attenuation. Anything that is attenuated does not reach the image receptor. Remember, only photons that go directly through, don't hit any tissue, are black. Photons that are scattered just add a density but don't provide any information. So we're looking for photons that are fully or partially absorbed. We're looking for a range of intensities from black to white and all the shades of gray in between. So we acquire the image, then we analyze the image, and after analysis we can either tweak or post-process that image or send it as it is. But the bottom line is the image you send to the radiologist is the image that they will interpret. An anatomically programmed radiography system is a system of pre-programmed exposure technique settings that is organized by position and procedure and set through the control panel of the radiography unit. These are vendor specific. APR settings commonly provide recommendations for small, medium, large adult patient sizes and a combination of AECs to choose from. The physics or the foundations of radiographic exposure don't change simply because you use a different type of image receptor, either film screen or digital. But how you apply them does change based upon the image receptor that you're using. When producing images using digital technologies, radiographers still must determine the radiation exposure needed to produce a quality image for interpretation. The physics of technique just need to be applied to the new image receptor. Let's take a look at the differences between film screen and a digital acquisition image receptor. If we used all of the techniques like we did in film screen, we would actually degrade the image that we're trying to acquire. We would lose contrast and sensitivity. We'd lose sharpness and spatial resolution. We'd lose the dynamic range. We'd get an increase in noise. And we'd get a decrease in the system speed itself and have geometric distortion and end up with artifacts. This gives us a decrease in diagnostic accuracy, an increase in observer time and fatigue, trying to compensate and read for these images that are acquired using the wrong techniques. The idea is you use film techniques and you use digital imaging techniques for digital image acquisition. So very simply, mass is the amount of radiation or data signal. KVP is the amount of penetration. What we have to understand is that we need to apply the mass KVP for digital images so that it can be picked up on the image receptor as a histogram that can be transferred into a lookup table to assign the shades of gray and the position for those shades of gray on the display monitor. The table determines image quality and contrast, not the exposure. Let's take a look at patient dose. We always worry about how much dose our patient's getting, whether it's CT dose or X-ray dose from this or from going in and having fluoroscopy or interventional procedures. But realistically, in the ionizing radiation that is used in medical imaging is low-dose ionizing radiation, as opposed to the radiation that would be used in therapy, which is high dose. Low-dose radiation does not have an effect on the patient until we reach 1 sievert or greater. So realistically, whether we're using CT or an X-ray piece of equipment, we're not giving the patient a whole lot of dose if we use it correctly. Now, the big thing about dose is in trying to save dose, we might underexpose the patient. If we underexpose the patient, we're going to end up with a noisy image, not as much detail, etc. So we'll end up with an image that looks salt and peppery. On the other hand, to try to combat that, some people start going, oh, let's say you use 5 mass at 80 kVp. I think I'm going to use 10 mass at 80 kVp. That way I know I'll not be underexposed. Well, yeah, you will not be underexposed. You're not going to have a noisy image, but the patient is going to be overexposed. It's a risk versus benefits. And dose creep, has been documented very carefully in medical imaging. Back in the olden days, when we used film screen, image capture, storage, and display was all done on a film. Today, we use digital imaging. In digital imaging or electronic imaging, the functional parts of the conventional radiography have been separated. They're new categories. We have a category for image capture. We have a category for image storage and a category for image display. It's what we're doing with the data and not doing with the film. We don't have a film file room. We have a server. Remember I said in the olden days with film screen, if it was too dark, you cut the mass in half, or you reduce the exposure by 15% of the KVP, And if it was too light to compensate for it, you doubled the mass or increased the exposure by 15% in kVp. Today we use exposure index. The problem with the exposure index indicators are each one is specific to the manufacturer and they all have proprietary information. So you really need to understand what your exposure indicators are for your equipment and how to utilize them. Here we can see the ranges, and we can see that there is a difference between Fuji, Agfa, Carestream, and DR detector exposures in millirinkins. What do we need to do with these? Well, we need to be able to understand how they're utilized so we can either repeat it or tweak it. Let's take a little closer look. Here's a quote from the American Association of Physicists in Medicine. Common exposure indices and deviation indices to be implemented across all digital radiography detector types and across all manufacturers and vendors of such equipment. Whoa, what are we talking about here? What we're talking about is each manufacturer has their own exposure indicator and you need to be familiar with it to operate the equipment. The value of the exposure indicator system or mechanism is to provide feedback to the radiographers as to the adequacy of their exposure technique. However, with manufacturer-specific exposure indexes, often people become confused. And another thing to think about is all of this is based upon doing things correctly, which means your equipment has to work right. Exposure indicators only work with calibrated equipment. God, do you remember the days when they used to go, oh, room 1's shooting +2 and room 3's shooting -1, 4 and 5 are okay, and up in surgery, God knows. Actually, what we're looking at here is to get quality images. All of our equipment needs to be calibrated. The acquisition equipment, the monitors, everything needs to be calibrated and integrated to work together. Take a moment and look at this slide and you can see the differences in the EI and DI numbers with mass, and you can also see the different types of deviations that you can end up percentage-wise, like in the Toshiba calculations. Again, manufacturers often recommend exposure indexes that are set too high so that their equipment looks good. You know, a lot of dose in there. It is recommended that you actually go in and optimize all of these when you get your equipment to begin with, and then continue to optimize them by utilizing the software within the equipment over the period of time that you're utilizing it. Notice here are some of the terms that we saw on our exposure indices. The exposure index, the target exposure index, the deviation index. Again, these are all in DICOM, Digital Imaging Communication in Medicine. And here we can see what they are specifically meant to determine. Well, once we get the exposure indices, what do we do with them? Well, we have a range of action. On the DI, anything that's greater than a +3 provides excessive patient radiation exposure, and you should repeat only if the relevant anatomy is clipped or burned out, and it requires an immediate management follow-up to find out if it's the equipment or the tech. For DI, a 1, 2, 3 is an overexposure. Again, repeat only if the relevant anatomy is clipped or burned out. At 0.5 minus and 0.5 plus, that's the target range that we're looking at. If we go down and we look at an underexposure, that would be less than 1 or less than 3. If it's less than 1, consult the radiologist to see if you do need to repeat it. If it's less than 3, you're going to repeat it anyway. So that's how we utilize the exposure indices, and we have to have some sort of control limits to tell us what to do, how we've interpreted them, and what actions should be taken. Let's talk about automation. We're talking about automation with digital imaging, but let's switch it over to make it a little bit more fun. Let's talk about automation for autopilots on planes. Now, with that, we get expectancy errors. In other words, the pilots are always relying on the autopilot to fly the plane. In reality, they just do landings and takeoffs most of the time. So what you're looking at is, if there was an emergency, do the pilots still have the manual skill levels to work with the equipment? Programming errors. Well, didn't we have airplanes grounded for quite some time because they had some errors in their software, which caused the planes to crash? Remember, garbage in, garbage out. This would be the same for X-ray as it is for airplanes. How about information overload errors? What we're talking about here is you get so overloaded with the technology and the information coming from the technology, you forget what you're actually looking for. You need to go back to some of your basic skills. Why am I shooting this image? What do I want to see? What does the radiologist want to read? And lastly, you have your basic technical skills because you haven't been using it, because they've been automated. You haven't been selecting all the techniques. You've been pushing the anatomical button. Can you sit down today and do a technique chart in your head? Or do you need to revert to luck? Automated systems and autopilot features on imaging modalities are causing automation addiction among today's technologists, weakening their response to improper technique application, mechanical failures, and emergencies. Thank you for your time and interest, and we look forward to having you at some more of our Masters presentation series.